Hi, friends. Welcome back to another episode of the ASAP Pathway podcast. Again, we have two hosts today, myself, Dr. Stacy, and then we've got Dr. Tracy. And I am really excited. I always say I'm really excited, but I am. I'm so honored to have the guests that we have on because it's just such a necessary conversation. But we have Dr. Alan Reisinger. Is it the third? Do you prefer to have the third after your name? Dr. Alan Reisinger the third.
Not necessarily. The other two are
Okay, I
fine.
didn't know if that was specific for you. We have him here today, and Tracy, you met him originally at the ADA, or
Yeah.
didn't you? With the ADA's big launch of the oral systemic connection.
Yeah, I met Alan, Bob, or Robert Lutzig, and Brian, all at the ADA because we were all speaking that day. So it was a really great, like, nice little eye opener connection. I mean, I like that the ADA now is like, hey, we really need to start communicating with our physicians and understand that it's all connected.
Yeah,
Yeah.
100%. I'm proud of the ADA for giving so many good speakers platforms and spreading information. Um, a lot of people can say, "Oh, I don't want to be part of a larger, group within my, organization, whether it's the ADA." But I think it's so important, and I think the ADA is doing a lot lately, and I'm really happy to be a part of the ADA.
Yeah,
Um,
I would just say, as a medical doc, I was so impressed at the ADA meeting in Chicago last summer that every executive at the ADA was on board with connecting, or I should say, reconnecting medicine and dentistry. And
Yeah.
I had no idea that the dental community, some of the leaders in the dental community were that passionate about making this happen.
well, I
You know,
love
I
it.
think I
Yeah.
think it's interesting that you say that because I feel like dentistry, we it's ingrained in our heads in dental school, like that we need to have collaborative care. Like when we do like full mouth rehabs, we have specialties for every group. And it's almost to the point that we're like, if you're not qualified to do this, you need to grab a specialist. So hence why dentists are very good with collaborative care. We'll always refer. But I find like I don't get the same kind of relationship with physicians,
No, it's
and
true.
so
Physicians are, I mean, we are used to that type of collaboration. We'll refer out to a gastroenterologist or a
Yes.
cardiologist. However, I mean, I guess we'll get around to telling my story at some point and how I came to be involved with the dental community. But until I did that, until I realized how important my local dentists and hygienists were to the overall health of my patients, the only reason I ever interacted with the dental community was to give my opinion on whether they could stop their anticoagulation or whether they needed
Yes.
antibiotic
yeah.
prophylaxis
That is
for
it.
pericarditis. Yeah.
That is it. And I think what Tracy said, and then I'm going to jump into the bio. And you actually, that was my first question for you is going to be how you got started in this. But we are good at referring to specialists within our professions. But I think we struggle with, I know personally within the airway community, the first thing that's new for an airway dentist is, okay, now you have to go out and you have to start collaborating with medical doctors and sleep physicians and ENTs. And they're like, we weren't taught how to do that in dental school. So we're
Mhm.
good at referring within specialties within our, but not necessarily the cross collaboration. So,
Agreed.
okay, I am going to introduce you, Alan. You're a pretty impressive man. Okay. Dr. Reisinger is MDVIP's Associate Medical Director, and we'll get into what MDVIP is. He practiced for 35 plus years as a board certified internal medicine specialist with a heart for people, a focus on prevention, and a desire to see primary care delivered the way it was intended. Serving as a member and subsequent chairman of MDVIP's Medical Advisory Board, he's helped to lead the clinical direction of the organization since 2008 and has been a passionate advocate for aggressive cardiovascular prevention in the network. Previously, he was on the medical advisory board for Cleveland Heart Lab and currently is a member of the Bale Duneen Academy. Did I say that right?
Yes.
Okay.
Valentine.
Bale, okay. A fellow of the American College of Physicians, a member of the American Society for Preventative Cardiology, and an advisory board member of the American Academy for Oral Systemic Health. Integral to his calling is his commitment to improving patient care, and he is resolute in the need to foster enhanced collaboration between the medical and dental communities. He has lectured nationally on cardiovascular disease prevention. He has embraced the mission of changing the outcome of cardiovascular disease, the leading cause of death in the world. And I love this because we can. And that's it. We can. And it's not known. It's like a big mystery, you know? It's
Yeah.
like, so how did you get started? Cardiovascular, what's going on?
So, I practiced for 10 years as a traditional private practice internist back in the 90s when everybody in medicine was selling their practice to local hospitals or large medical entities. We ended up selling our practice to the local hospital. I became president of an employed physician group, all primary care, OBGYN, pediatrics, and internal medicine family practice. And after about a decade of that, and realizing that we were stuck in this assembly line medical medical world where people were being moved in every 15 minutes and out again, and you had your hand on the doorknob while people were trying to explain their issues. And I couldn't do it anymore. I mean, I was ready to bail. And then my partner at the office and I discovered MDVIP, which stands for Medical Doctor Value in Prevention. And
I
we
like that.
realized that there was a better way. So we bailed on traditional medicine. We became MDVIP physicians. And the basic premise of MDVIP is that patients pay an annual so-called membership fee, which covers an executive physical, something you'd go to Hopkins or Mayo or one of the, Stanford, one of the major tertiary care providers. And you basically get a 2.5 hour physical that includes lab tests and EKG and hearing and vision and peripheral arterial assessment. And it's a total body evaluation that goes so far beyond the standard of care. We're looking at advanced lipids to determine your cardiovascular risk. We're looking at whether you have vascular disease already, subclinical atherosclerosis, which is incredibly important. If you've got that, you've got the raw material for an event to happen down the line. Um, Probably almost as important, although we're not allowed to talk about it, is that you have access to your doctor 24/7. You're able to get in to see them the same day or the next day if there's an urgent problem. And you can talk to them on the phone on a weekend or on an evening if you've got an issue. And what I found subsequently was that my patients, I got to know them better than I had in the last 20 years. And I was able to give them better care because we had the luxury of time to discuss issues that we really didn't have time to talk about before: stress management and sleep and nutrition and exercise and so on. So that was an amazing revelation for me. And then about 3 years later, I found myself at a weekend-long preceptorship called the Bale-Donine Method, which I suspect many of your readers will have heard of. And there are these two doctors that aren't cardiologists, but that have devoted their careers to researching the current literature regarding cardiovascular prevention and applying the science, applying the well-documented science before it becomes part of the guidelines. And as an aside, there was an article in the British Medical Journal that showed that it takes about 17 years for new science to make it into the guidelines that medical doctors practice by.
Mhm.
So they basically circumvented that 17-year delay and are applying current science. And it is now 25 years that they've been doing what they're doing, and they give their patients a written money back guarantee that they will not have a thrombotic stroke or a heart attack on their watch. And in
Wow.
25 years, they've given 3 people their money back. And they have some of the sickest patients from around the world that come to see them because they've heard about this method. So when I came home from that preceptorship, my head was spinning. I thought, oh my heavens, I've got all this time with my patients, and it's still not enough. Because part of what this program entailed was bringing medical doctors and the dental community together, dental doctors, hygienists, myofunctional therapists, et cetera. They opened my eyes to the contribution of oral health to systemic health. And all of a sudden, I was communicating with my patients' dentists, their hygienists. We were collaborating on patient care. And over my next 10 years of practice, until I retired from my clinical office, I never had another patient have a heart attack or a thrombotic
Mm.
stroke. And at that point, I was chairman of the medical advisory board at MDVIP. And I said, we have got to expose our doctors to this type of medicine, to this program. We need to make this something that every MDVIP doctor is doing. I would love to see it become part of what every physician in the country does, certainly the primary care docs. So that's the short version.
That's the abbreviated version. Well, I mean, the things we had talked about a little bit before we hit record were the information is there, but we're not seeing this like if we can prevent a heart attack, we can prevent a thrombosis, we can prevent those things. We know how to do it. This information just isn't getting out fast enough. It's that patients listening, people, human beings listening would love to have, I'm sure, these protocols incorporated in their families. What is, what do you think the limitations are? Why isn't this information becoming more widespread and known?
Oh my heavens. Well, part of that just simply has to do with the fact that academic medicine is a cruise ship, not a speedboat.
Mm,
So
yeah,
if the captain decides that it's time to make a turn, it takes, hours,
true.
not seconds.
That's a good point.
Um, you
Oh,
know, Translated to years or decades and not days. There's a German philosopher back in the 1700s, Arthur Schopenhauer, and I love what he said. He said, all truth passes through three stages. First, it is ridiculed. Second,
yep.
it is violently opposed. And third, it is accepted as being self-evident.
Yes, isn't that?
So we see that all the time in the field of medicine. And it's just tough. If doctors didn't learn something in medical school, it can't be true until their big medical societies finally embrace new technology, new advances, and say, okay, yeah, we're going to put this in to the guidelines because now we've had 16 randomized placebo-controlled trials that lasted 15 years, and okay, we can prove that this is a good test to add. Except by that time, we've already surpassed that test, and we've got something
Yeah.
better.
Well,
So it's tough. That's a big part of the reason that this isn't happening. We're just
well,
behind.
one of the things you had said in one of our ASAP monthly member meetings that it just hit me like, wow. What you were talking about the science of studying science and
Hmm.
how, 50% of what we acknowledge as fact within science will be expired or known as not the case any longer. 50% within what, 10 years?
Within 10 years, the trouble is we don't know which 50%.
Which
Yeah.
50%?
You know,
And that's true. It's true. I mean, we're advancing, so rapidly, and we're fine. And somebody else once said, and I'll probably get this quote wrong, but medicine advances one funeral at a time. And what they meant by that was that we have these icons in the medical field that have done research and that have their minds made up about a certain approach to a disease. And as long as they're still alive
Yes.
and spreading their gospel, we ain't going to move on. We're
We
not.
have that in dentistry, Alan. We
You
have
do.
that in today. Yes, we
Okay.
do.
Yeah. So,
Good. Okay.
Al
Okay. Got it.
Alan, talking about like the standard physical, right? So it's interesting because like I had a standard physical and with all these testings, and then I actually paid. I think there's a program called Functional Health by like Dr. Mark Hyman.
Hmm.
So like you get about like 500, extra tests.
Yeah.
And I thought I was like, oh, that's great. I like that. But the problem with that is that you don't have anyone to read all of that,
Right.
and so then I was thinking, gosh, it'd be so tell me a little bit, about, you talked about the annual cost and what that covers. Just from a patient standpoint, like what makes a wellness visit with an MDVIP doctor different than like a standard primary care? Like, why would I want to go have an annual membership with an MDVP doctor?
Yeah. Well, I'll tell you, Tracy, having practiced as a standard medical doctor for 2 decades, I'm
Yeah,
embarrassed to answer that question, because the standard, especially in today's world where the vast majority of primary care doctors are employed by an institution or organization, that, is looking at throughput and,
yeah,
how many patients can you see in a day? And how efficient can you be in that process? And so the standard, in quotes, air quotes, physical,
yeah,
annual physical lasts at most a half an hour across the country. Your doctor may not even undress you for that visit. They may put their stethoscope over your shirt. You'll get your vital signs taken. They'll ask you a few questions about what medications you're on, and you might get a standard lab panel with a sugar and a hemoglobin A1C for long range sugar management diagnosis, some kidney and liver tests, a blood count, and this cursory exam. Your doctor doesn't have much time to talk to you about the most crucial elements of health, which are sleep, stress management, nutrition,
yeah.
exercise, and oral health. And God forbid your medical doctor mentions anything about oral health, because that's taboo. That's not, something they're familiar with. And then you're sent on your way. And so um, at MDVIP, this annual wellness program, now the patient pays, I think the starting membership fee is around $2,500 nowadays,
Hmm.
per year. But what that covers is this remarkable 2.5 hour annual wellness program visit, at which time you get all sorts of testing done, not just the standard stuff. What's your sugar?
Right.
What's your LDL cholesterol, which is actually not the number we should be looking at for cardiovascular prevention. We'll talk about that later. But you get testing for peripheral arterial disease, vision and hearing screening, dementia, early minimal cognitive impairment screening. We get a chance to talk about what are you eating on a daily basis? How much activity are you getting? How's your sleep? Does your partner say that you snore? How do you feel when you wake up in the morning? What are we going to do about the stresses of work, of kids, of family issues, of politics? How do we handle that, and how is that impacting your health? How often are you getting in to see your dentist? And then let's look at some labs that you'll never get in a traditional medical practice. Let's uncover any evidence of systemic or vascular inflammation, which is the underlying cause of every chronic disease of aging.
Yeah.
Let's talk about your oral health. Let's look for the earliest signs of insulin resistance, the
Mm.
precursor to prediabetes and then diabetes, which underlies 70% of the heart attacks, the vascular disease that we see in this country. And then let's create a wellness plan, a business plan for your health, so to speak, and let's put it in writing. And then I'm bringing you back every 3 to 4 months so that we can make sure that we're on the same track, that we're getting you to your life goals and health goals. And you can get some of that guidance at one of these executive physical places that you, at Mayo or Hopkins or wherever, and they're great programs. The problem is you then walk out with this booklet of
Oh,
recommendations that your
Yes.
primary care doctor doesn't even have time to open.
sure.
Whereas in the MDVIP model, the person who helped you to develop that business plan for your health is the person who's going to help guide you through that plan over the course of the coming year.
Speaking of just all that, the different labs, the different biomarkers, the reason that I would love for you to explain to the audience that isn't familiar with this. What opened your eyes to how working with oral physicians, which is what I really feel dentistry is, we're not mechanics. I mean, you can choose to be a mechanic, but you are capable of so much more.
Right.
Um, so, what was it that you saw that, the hygienist, the dentist, what could we be looking for? There's different pathogens that that if we get the bacterial load down on our end for your patients, this big beast of inflammation, we can at least take pieces of this inflammatory puzzle apart together.
Sure. Well, as so many of these stories do, this one involves one of my best friends who happened to show up at my office the week after I came back from this preceptorship, and I was on fire, so to speak, learning about arterial fire and about insulin resistance and about salivary pathogens and their contribution to systemic inflammation. Well, I had done some of these fancy labs on my buddy, and every one of the inflammation markers was elevated. It was significantly elevated. This guy was on fire from the inside out. He had no idea. He didn't feel any of that. But because we went the extra step and did these markers, I could see that he was in trouble. And we know that in the majority of cases, a heart attack when it happens is not because you slowly put sludge into the artery wall and eventually block off an artery and have your lack of blood supply to the heart muscle. No, most heart attacks happen because you've got plaque that was sitting in your artery, not causing any problems, minding its own business. You became inflamed for whatever reason, and that plaque became irritated, inflamed, and it ruptured, and then a blood clot formed at the site of that rupture. It's the blood clot that stops blood flow and causes the heart attack. And so when I saw that degree of inflammation, I panicked. I said, what could be causing this? Well, one of our jobs in primary care and really in medicine and dentistry in general is if you find something like that, you're not just treating the lab test. You want to look for the root cause. What's behind
Mhm.
this? Is it a dental abscess? Is it periodontitis? Do they have inflammatory bowel disease or psoriasis, or any of a host of things that can create systemic inflammation? In my buddy's case, I, for the first time in my 20-year at that time career, I decided to actually look in his mouth at his gums and teeth. In medicine, the gums and teeth are serve as a rest for the tongue depressor, so that you can just look to see if your patient still has their tonsils. Well, I
Yeah.
looked at his gums and they were red, and he had recession of gum tissue. There was a couple bleeding points. I asked him about whether his teeth bled when he brushed his teeth. I never asked that question before. And he said, well, yeah, every day. But, I figured that's normal.
Mhm.
I told him at that point, your teeth should bleed, your gums should bleed as often as your eyeballs. So we need to figure this out. I called his dad. Oh, and at that point, I ran salivary diagnostic testing on him, which I had also never done in my practice. And sure enough, he had four of the five keystone pathogens, the red complex pathogens present. At
Mhm.
that point, I picked up the phone and I called his dentist. And we had a very nice conversation. She was not aware of salivary pathogen testing. She was aware that my buddy had missed his last couple of years of dental visits, and at their last visit had two teeth that needed to be removed and a fair amount of periodontitis, but just they weren't bothering him. So
Yeah.
it,
Yeah.
it wasn't top of mind for him. Well, again, to make a long story short, I put him in her hands, and 6 months later, every one of his inflammation markers was back to normal. He had
Mm.
those two non-viable teeth removed. The hygienist worked aggressively with him on his perio care at home and at the office, and all was right with the world. And we prevented his heart attack or thrombotic stroke, I'm convinced, by finding and fixing this inflammation, which happened to have a dental origin.
Well, I really do, and you've said this, and Robert Lustig has said this, Nathan Bryan has said this. The next 5 years are going to be really interesting, 5 to 10 years, knowing how it traditionally goes a little slower. But, the collaboration between medicine and dentistry has to be, like you said so well, reconnected, not connected. We were connected.
Right.
We have to get reconnected. The oral microbiome, dementia. We have, Parkinson's, heart issue. I mean, there's all these different things happening in the brain that we know that something's going on with the oral microbiome, um, dysbiosis, and even gut health. There's just so much coming out with all of it that we
Sure.
have to start communicating and just talking more. We don't have all the answers, but we know enough to start making a difference just from what you're talking about today.
No, you're right. And it's heartening to see that the American Dental Association, the American Heart Association, I mean, the American Heart Association paid lip service to this concept 20 years ago, when they said that there is level A evidence that periodontal disease contributes to or is associated with heart disease.
Mhm.
They made that association. They didn't specify that there was a correlation. There's a correlation,
But
not
not a
necessarily
causation.
causation.
Yes.
We have since then plenty of evidence that indicates causation. And it's heartening to see that the major medical and dental societies are actually publishing studies and publishing reports that are indicating that they're recognizing this connection and they want to see more done about it.
So in your experience, at what point so for the average medical doctor listening right now, what is the classic patient that they should start somewhere with and say, okay, I'm seeing A, B, C. What are these things that I need to ask that patient? Do you have a dentist?
Ah,
We need to get your dentist involved here.
yeah.
What is that? What kind of patient, what kind of signs would a medical doctor see that would flag them to start thinking outside the box and working with the dentist?
Sure. Well, I mean, the easiest answer, and the most probably the one that would impact the greatest number of people is, if we're talking to a medical doctor, if you've got a patient who's got insulin resistance, pre-diabetes or diabetes, and that now encompasses over a third of the nation, sadly,
Yeah.
then that you need to ask that person if they're keeping up with their dentist, because there's a bi-directional relationship, as you all know, between diabetes and gum disease. The worse your gum disease, the worse your diabetic control, and the worse your diabetic control, the less capable your system is of fighting off these periodontal pathogens. So if that were the only thing that medical doctors did, that would contribute significantly. I think the statistics are that 90% of diabetics have got periodontitis. Well, that's sad. That's fixable. And unfortunately, I don't think even the dental community is as aggressive about going after these salivary pathogens as they could be. And here again, I think most of our current dentists in practice didn't hear about salivary pathogens in dental school.
Hmm.
And so, all truth passes through three stages.
Yes,
And,
it does.
we're, well, I think we're in the violently opposed stage for many of our dentists. Tracy, you'll remember at the ADA conference, we had a periodontist that was really giving us a hard time about this stuff.
Yes, he was. He was just like, all you need is omega threes. We're just like, that's all you need to get rid of the pathogens. I was like, but no,
Yeah.
I mean, it's well, that brings me to the next point. Like education. I mean, you guys have about what 1,300, 2,000 doctors in your network now.
Yeah.
How do you guys
About
have like
1,450. Yeah.
yeah, do you guys have conferences where you educate like how you calibrate each other?
Ah,
Because like when I think
well, yeah.
about when I think about dentistry, I mean, when patients are looking for dentists, they really should look at the dentist's education level, the calibration, what other things are other advances. Because like, from a dentist standpoint, the average dentist, you only need 15 hours of continuing education to satisfy your license. But
Hmm.
the reality is like ASAP members, I mean, we're doing like hundreds a year, and so like I can honestly say that I know our ASAP members, I mean, they probably do at least 100 hours in education a year to kind of calibrate our knowledge being very current.
Right.
What can a patient expect from the MDVIP doctors? Because I feel like regular doctors, just like you said, they're not current to even salivary testing, things like the connection.
Right.
But
Right.
how's the education level for your doctors?
Well, the first thing I would say is that this luxury of time that the MDVIP doctors have, um, it probably makes the biggest impact. There's other things that I'll talk to you about, Tracy, that play a role here, but just the fact that you have time to listen to your patient. I had a professor in medical school that said to me, Al, um, if you listen to your patient long enough, they will tell you what's wrong with them.
Mm,
All these fancy diagnostic tests, they're helpful, they're handy, they're good to have, but just listen to your patient, and they're going to tell you what's wrong with them. So we have the time to listen to our patients. We have the time to research anything that comes up in a visit that we might not be familiar with. Whereas in traditional practice, you figured out what test you would order or what specialist you would refer the patient out to because you didn't have time to do that research and to think about things or even to pick up the phone and call a specialist and say, look, I've got this patient that's got so and so. What do you think? What's the next thing I should do? Do they need to see you? Do I need to get some studies first to clarify? So that luxury of time is really important. The other thing that causes our docs, who were all just regular run-of-the-mill primary, I mean, I shouldn't say run-of-the-mill. We bring doctors in who are passionate about preventive medicine, about patient care, about really getting to interact closely with their patients and not be a part of that assembly line. Uh, Part of the MDVIP program is this portfolio of labs that every patient gets every year at the annual wellness program visit. And in those labs are included advanced lipid testing, which most medical doctors don't use yet,
Yeah.
but they will. They will be. And inflammation markers, which the vast majority of medical doctors don't use because there isn't a single drug available for inflammation, systemic or vascular inflammation. And so because there's not a drug and because the pharmaceutical industry isn't plastering advertisements all over the medical journals and TV, and because inflammation testing isn't part of the medical guidelines yet, but it will be. We're not seeing this done in traditional medicine. Well, when our docs know that they've got to be ordering these tests, interpreting them, and explaining them to their patients, they're highly motivated to learn what to do about them. And that's been my job at MDVIP for quite a while is participating in the education of our physicians. So we have monthly webinars that we do, multiple monthly webinars. We have something called the MDVIP Academy, which is a monthly email that goes out by our Director of Education and Clinical Excellence, Dr. Lou Malinow. And he's always touching on some of these, I'll say, esoteric topics in air quotes, because they shouldn't be esoteric. They
yeah.
should be standard, but they're not in the
Yeah.
guidelines yet. We have national meetings that occur every 2 years where we bring in some of the, cutting edge key opinion leaders in the medical field that teach our docs about this stuff. And we are constantly looking for the leaders in the field, the people like Grail Gallery, the multi-cancer liquid biopsy blood test out there that tests for 50 different cancers. We're partnering with them to give our patients access to this. The technologies like Clearly, Cleerly, this is artificial intelligence applied to a coronary CT angiogram
Hmm.
to do a better job than a coronary catheterization at telling us the status of our patient's coronary arteries, and whether they've got plaque for sure, but what's the flavor of that plaque? Is it soft,
Mhm.
dangerous, and ready to rupture? Is it old news, calcified, stable, nothing we have to worry about? Is it somewhere in between? We have technologies out there now that can tell us who's going down the path to a heart attack before they ever have a symptom. And so we're partnering with those folks, and we're constantly educating our physicians on these newer technologies.
What is the group? So the MDVIPs, you guys, I mean, I think it would be so great to have this newsletter access. Can anybody get this access to this newsletter for MDVIP?
Not to what the physicians get specifically, but we also put out a monthly newsletter to our patients. And we've got over 400,000 patients across the country, and they can share this with friends, family,
Beautiful.
so they
Okay.
have access to this. Yeah, for sure.
So when you are encouraging your MDVIP docs to look for a dentist that understands oral systemic health, what is the equivalent group, if you will, of dentists that have this kind of knowledge that are collaborating well with MDVIP docs? Is there an academy, a group that you would recommend dentists go to get educated and be part of?
Well, I mean, I can only speak about what I know about, and I've been connected with AOSH, the American Academy for Oral Systemic Health,
Mhm.
for quite a few years, and so they are obviously, if you just look at their name,
Yes.
uh, they're passionate about the topic that we're discussing today, and I mean, their mission is to bring medicine and dentistry back together again. They have a wealth of educational topics on their website that members have access to, and we're in the process of bringing that even further up to speed with current medicine. But I think there's a lot there, and they've got a directory as well, because that you hit on a very difficult point, Stacy. It's tough to find dentists, just like it's tough to find medical docs
Yeah.
who are savvy about inflammation and the role of oral health to systemic health. It's hard to find dentists
Mm.
who are interested in communicating with medical doctors, and who even are using salivary pathogens. So we'll use the websites of some of the major salivary pathogen providers, the ones that have directories. We'll tell our docs to go on those directories to look for dentists who are utilizing salivary pathogen testing. We assume that those folks are maybe more up to speed with this technology and this science. We'll refer them to the Bale-Deneen method website, because they've got a directory of dentists who have gone through their preceptorship program and who are obviously savvy about this stuff. But it's not, and you guys do a better job than we do about education. I'm just sorry. I mean, there's no such thing as a medical study club once you get out of residency, and I know that there are
I
dental
keep
study
hearing
clubs.
this. I keep hearing this from MDs. They're like, you guys in your dental study clubs, we don't have anything like that.
Yeah, yeah,
Yeah.
wonderful. And I mean, I think that if we could get more medical doctors to come to dental study club meetings,
Hmm.
maybe not the ones that, I mean, we just need to have medical docs as guest speakers at these study club meetings, so that, we can get a more personal introduction to how our fields intersect.
That's a
Yeah.
that's a really good point. if for all the dentists listening, so we've talked to some of the MDs listening, where, what you can start doing and looking at to start saying, maybe I need to work with a dentist. So we in dentistry do know there are definitely we knew about the correlation very confidently of diabetes, periodontal disease, heart disease, a lot of the issues with brain health, dementia, et cetera. But the causation, I think dentists feel probably a little less confident about, but now we know there's research, there's causation. But then
Yeah,
I think dentists still feel a little bit like, yeah, but other than what do I do scaling and root planing, I do gum therapy, right? Get a tooth out. I recommend a tooth come out. How do we empower these dentists to say, what's a step they can do beyond? And it sounds to me like salivary testing, like to start with looking at different companies, that reputable companies that offer salivary testing to show the specific pathogens. So you can sit side by side with that patient and say, look, you have these four, three, five out of the five pathogens that are in research, and then they show the evidence. These are the
sure.
pathogens that are in your mouth, and this is what it's causing. I feel like that's like a first step for dentists. Is there something that you wish more dentists would like open their paradigm a little bit more and start doing just as
No,
a
you've hit the
first
nail
step?
on the head, Stacy. It's absolutely salivary diagnostic testing. I've had the great pleasure over the past several years of lecturing together with Laura Hooper.
Oh, yeah.
And many of your dental folks will recognize that name. She's an icon in the salivary diagnostic. I mean, her moniker now is the saliva hacker.
Yeah.
But she's one of the pioneers in this field. She's been doing salivary diagnostic testing, both doing it and teaching it for over 2 decades. And we've got all of this evidence that let's take Porphyromonas gingivalis, PG,
Mhm.
one of the main bad actors in salivary pathogen world, which we found this bacteria in the brains of people with Alzheimer's disease. We know that it causes a systemic inflammatory response that releases cytokines, chemokines that contribute to the pathogenesis of atherosclerosis, of dementia, of heart attacks, of strokes. And, I always, in my lectures, say to the group, if you had an infection, if you had a type of bladder infection that could lead to a heart attack, a stroke, or dementia in your patient, would you really just want to shoot from the hip and write an antibiotic without
Yeah.
doing a urine culture and knowing what that infection is, what it's sensitive to, what you should be treating them with first line? And everybody who comes to these lectures says, well, of course, we'd want to know what the pathogen is. Well, the same thing applies in the field of dentistry with salivary pathogen testing. And these pathogens, the major pathogenic bacteria in the mouth, are not responsive. At least several of them are not responsive to scaling and root planing. You need systemic antibiotics to treat those. And I know that many dentists are opposed to systemic antibiotic use unless it's absolutely life-threateningly necessary. But it's a part of the treatment here. Particular products that you should be using or not using in the dental office and at home for your patient's dental care. These are all important, and they're all things that you can discover by utilizing salivary diagnostic testing.
Yeah, I think it's something I started implementing about, I want to say a year and a half ago, and I was very hesitant and I'm a very open dentist. So I'm thinking to myself, good grief, I'm a pretty open dentist to these things. And I was even hesitant to start, okay, now I'm going to put you on an antibiotic because I'm seeing in this report, my scaling and root planing alone isn't getting these bugs under control.
Right.
So we have to change what we're doing here. And no one else is going to conquer these bugs. So I had to start doing it. And then you retest, and it's just very satisfying and interesting. So
Yeah.
for how do we get local dentists plugged in to find a local MDVIP doctor? Do they go to a website? Can they find
Yeah,
a provider near them?
there's a website. It's MDVIP.com, so that's pretty easy. And they basically would get on there, plug in their zip code, and see who's around in their area. I mean, I would make the disclaimer that not every MDVIP doctor has been exposed to all of this information yet, but they are all savvy about inflammation testing and management, and they're if I do my job properly within the coming year, every single MDVIP doc will have an oral systemic mindset. But they've all heard about this. Uh, I guess you asked earlier, well, how do we get medical doctors thinking about, when they should bring in their dental community to
Mhm.
patient care? Anytime that they discover a patient's got evidence of systemic inflammation, they should be thinking about the mouth as one of the potential root causes of that. And they should be alerting the patient and their dentist and hygienist that, this is something to be thinking about.
Well, this has been we really could and should continue this conversation. We might need a part two. I really, we appreciate you being here. I'm sure the audience listening today, hopefully they share this with loved ones because if this is the number one killer worldwide, everybody should know about this, right? This is the thief breaking into our homes, right? So we all need to be better understanding this topic, and I think really what drives change too is our patients being advocates for their own health and going to
Yeah.
their dentists and going to their medical doctors and asking for these things. The pharmaceutical companies figured that out. They
Right.
started going straight to the consumer. Ask your doctor about, if this
Mhm.
medication's right for you. We need to be doing the same thing. Ask your doctor if they understand the importance of working with the dentist. And ask your dentist if they understand about salivary testing and how it could help their heart and overall health. I appreciate you being here, Tracy, and I just are honored that you were here. I always end with some three random questions that have nothing to do with what we were just talking about. So if you're okay with
Uh-oh.
that.
Absolutely. I
Okay.
guess.
Okay, here we go. One, what is your favorite book?
Oh, Stranger in a Strange Land by Robert Heinlein.
Ooh, what is the genre? What's that book? Is it mystery or is it
Robert Heinlein was a science fiction author back in the 50s, and I read this book probably every year through high school and college and probably thereafter. And it's a science fiction book, but it's a commentary on human nature,
really?
on how we interact with each other, and basically how we should all be living together, working together, treating each other as part of one great big family,
Hmm,
rather than as Democrats and Republicans, or Europeans and Americans, or Martians and
right.
Earth people.
Such a good point. That's so funny you went there
Love
because
it.
my brain even was kind of going there myself. That's well, speaking of, you started reading this in high school. What was one of your childhood nicknames? And
Oh
give us
no, no, no. Next question.
come on, this is going to be good.
Tucky.
Tucky?
Tucky.
Tucky?
Tucky.
Okay, what's the story with Tucky?
Apparently, so my full name is Arthur Allen Reisinger III, and nobody wanted to call me any of that when I was a toddler. And apparently, I used to toddle around saying "tucka tucka tucka," and my old Sicilian uncle decided to start calling me Tucky, and that name chased me through grade school, high school, medical school, college, residency, and I mean, you name it. And
I
this
love
is the
it.
first time it's gone online, Stacy. So I don't know what to say. You
Now,
put me on the spot, and I revealed it.
well, you could,
That's
your family will probably be tickled that maybe the world will now start referring to you as Tucky, Dr. Tucky. What was the most interesting place? Where's the most interesting place you've ever visited?
Wow, interesting place. I would say the little tiny island of Ortigia, which is off of Siracusa, which is in the southeastern part of Sicily.
Wow.
My family originates in Sicily, and I went there for a mandolin workshop because I play mandolin.
I see
And
that in the background. I was wondering. Yes.
So just I mean the ancient history there, it's just a fascinating place. The food is amazing, and lots to learn about history and culture.
I love that.
Mhm.
Well, thank you for tolerating my three questions, and thank you for being here today. We so appreciate you,
Thank you,
and
Alan.
the mission that you feel called to do is so worthy and so necessary, and we appreciate you breaking away from tradition and following what you were called to do. We thank you for that.
Well, thank you. This has been a real pleasure. So Tracy and Stacy, thanks for inviting me on.
Thank you
Thank
so
you.
much. Thanks, everybody, for joining us. And if you'd like to know more about what's going on with ASAP, check out our What's Up in ASAP newsletter in the link as well. We'll have all these great links, ways for you to reach out with Dr. Reisinger, as well as maybe more information on MDVIP and how you can learn more about all of this necessary information. Thanks, everybody.
Bye.